Welcome to This Explainer. Today, we're diving straight into some highly anticipated observational data out of the annals of neurology, and honestly, it directly challenges a major, long-standing guideline in stroke management. Specifically, that strict 48-hour contraindication for giving IV thrombolysis to acute ischemic stroke patients who are actively taking DOACs.
Let's just jump right into the clinical dilemma, right? You're in the ED or the stroke unit. Your ischemic stroke patient is actively on a DOAC. Do you push TPA? I mean, current guidelines definitely say no, but real-world practice is really starting to ask, well, why not?
So here is the bottom line up front from this SITS-ISTER registry study. IVT actually appears safe. The researchers found literally zero statistically significant differences in hemorrhagic transformations, functional outcomes, or mortality when they compared patients on DOACs to those not taking any oral anticoagulants.
Okay, section SITS ISTR registry and methodology. Let's look at how they actually got these results. The researchers cast an incredibly wide net. We are talking about screening a staggering 135,194 IVT-treated stroke patients. This was done across 33 countries and 289 centers between 2013 and 2024. So yeah, definitely not some tiny retrospective. This is a massive, international, real-world snapshot.
Now, to handle the inherent imbalances you always get with registry data, they used a really rigorous 1-to-2 propensity score matching. This perfectly balanced out critical variables like age, baseline NISS, prior strokes, and comorbidities, narrowing the field down to 894 DOAC patients, matched against 1,788 NOAC controls.
But they didn't even stop there. To make sure this data was absolutely bulletproof, they went ahead and validated the findings with a doubly robust augmented inverse propensity-weighted or AIPW estimator model. It's high-level statistical rigor, basically designed to silence any methodological skepticism. Hemorrhage and safety outcomes. Let's see what the matched cohorts revealed.
The p-values here really speak for themselves. There is no statistically significant difference. Symptomatic ICH, using the strict SITS most criteria, was 1.1% in the DOAC group versus 1.5% in the control. ECAS-2 defined symptomatic ICH hovered right around 4% for both. And any parenchymal hematoma, 6.3% on DOACs versus 7.8% without. The bleeding risk simply didn't spike. It's kind of wild to see it so clearly.
Functional outcomes and mortality. Because, as we all know, safety is really only half the battle.
When it comes to efficacy, the results are striking. The modified Rankin scale score distributions at the 3-month mark show almost perfect parity between the DAOC and no-OC cohorts. The shift analysis basically shows the outcomes overlaid right on top of each other.
Statistically speaking, functional independency, which we're defining as an MRS of 0 to 2, was 47.9% for DOAC patients compared to 46.4% for controls. And 3-month mortality rates were nearly identical too, at roughly 25% and 24%. Active DOAC intake did not worsen long-term recovery or survival, period.
Timing of last DOAC dose. This is the variable we all sweat over in the ED.
The registry tracked time intervals from under 4 hours all the way to past 24 hours. And surprisingly, on a group level, there is absolutely no clear trend of increased hemorrhage risk with more recent intake. Actually, scratch that. It's even more counterintuitive. Ordinal multivariable analysis associated longer delays since the last dose with slightly more PH2 events.
The authors sum this up perfectly. They note, quote, "These results raise questions about the assumed dynamics of the last DOAC intake before IVT treatment," unquote. It hits the nail on the head. This challenges our textbook assumption that a highly recent DOAC dose creates this critically dangerous environment that completely takes TPA off the table.
Clinical implications for practice. How does this actually change what we do?
Well, mechanistically, it makes a lot of sense. DOACs inhibit fibrin formation, while TPA depolymerizes existing fibrin, right? They're targeting different pathways, so there's no obvious potentiation of hemorrhage. This really empowers us to strongly consider IVT, especially when EVT is off the table, maybe because of a distal occlusion or, simply being hours away from a comprehensive stroke center.
So that leaves us with the million-dollar question. Is it time to update the 48-hour contraindication guidelines? While we wait for the RCT results to come rolling in, this compelling registry data forces us as a stroke neurology community to ask if we need a complete rewrite. Definitely a paradigm shift to chew on before your next shift.